Hello, everyone.
Hello.
This is
Everyone.
Sadhana Alangar, HL7's Director of Education. Welcome to the Interoperable Proof of Vaccination Implementation Approaches Across Europe webinar. We have speakers from all over Europe to discuss this topic. And at this time, I'm going to ask Christoph Gessner, who's joining us from HL7 Germany and who's also on HL7 Europe's board of directors, to lead the discussion. Christoph, I can see that you're anxious to start off. Go ahead. Take me.
Thank you, Sadhana, for the kind introduction. So, welcome everybody. Over 100 attendees. Very happy to have you all here. And we will start this. I will just have a quick introduction here on this web conference, which is actually a quite spontaneous idea of. We have these regular meetings with all the chairs of European affiliates, and there was one meeting 3 weeks ago, and we said, well, we should have an extra meeting and exchange thoughts on what's going on in our countries with our affiliates with the vaccination stuff. So we decided that we would have an extra meeting, and then someone said, well, why don't we make it public? This is basically how this started, because everybody was happy with that idea. Next slide, please. Click. So the agenda today is quite loose. We have, I will give a very quick overview of the context. And then we will have 3 countries talking a little bit more in detail about the situation in their affiliate. And you will see there are different types of countries, different types of affiliates. And we tried to highlight this a little bit, that it becomes visible that we live in very different circumstances from country to country as HL7 members, as HL7 affiliates. And this will be continued with a larger panel with 6 or 7 additional presentations, also from one country which has an immunization system but does not have an HL7 affiliate. So that's also another perspective, that how can they work with HL7 if they don't even have an affiliate? And then we will hopefully have almost half an hour time for questions and discussions before we have some closing remarks from Catherine. Next slide, please. So just to give you some setting, some context. So this is a picture actually from ECDC, the European Agency for Disease Control. And it just shows everything around hypothetical immunization information system, may it be European or national or whatever. So what you see is the workflow kind of goes from top to bottom. At the top, you have the administration of the vaccine with all the logistics, and so that's basically healthcare workers and citizens working together, and potentially some data will be created on paper or digital. And then from this whatever system, the data are used for actually 2 different kinds of purposes, individual levels. So you have all these medical surveillance and ordering and statistics and recalls to the patient. And then on the patient side, the only thing that you had, at least in the past, was a vaccination certificate. Of course, if you have those data or similar data or whatever on paper or on Excel or in your IIS system, the purpose is also to do some things at population level. So that is from research to policy planning, supply chain management, safety issues, and all that. So this is the kind of secondary use, so to say. So this has been in place for, I don't know, 20 years or so, and in many countries these systems were already using HL7 standards, usually HL7 version 2, because that started in the 90s, and they are of course still running HL7 version 2. But newer systems are coming up, and And so there's almost, well, many countries in Europe have such a system in place. And this is not really the focus today. The focus today, as in the news, is mainly how can the patient benefit from that? So how can the patient benefit in a digital way from this fact that he was vaccinated, and maybe even vaccinated twice? So this certificate of vaccination, that's today in the news and in the focus of everybody. So just to give you a picture how this fits into this larger data flow. Next slide, please. Click. Yeah, so this one. Thank you. So the currently discussed things are, there are some pictures on the left just to visualize it a little. So when we talk about vaccination data related to COVID, there are basically three things that are discussed in the public currently. And one is the classical proof of vaccination for medical purposes. So what do we need in a digital yellow card? The second one is the one that is most controversially discussed, because the idea now is to use this proof of vaccination in this special COVID situation also for other purposes, non-medical purposes, travel, access to bars, to stadiums, maybe even for employment. There are big discussions, and of course these are political discussions, ethical discussions, and they are very controversial. And this is really a new thing in that sense. How much of the medical data do I want to give away to a doorman at a bar? And how do I technically produce such a tool that it's safe and does not enable us to do traceability and to track people more than necessary? So this is really the big topic. And then, of course, also, and I hope Sylvia can shed some light on that, that is the public health and research use, as I said before. Next slide. Yeah. So just very quickly before we go to the countries, national activities, you will see more than enough of that. So that's why I'm going to skip that one. But there is an important initiative on a European level, and it actually started in November already. As early as in November, there were the first discussions in the eHealth network. eHealth network is kind of, you can say it's all the ministries of health across Europe, plus the people from the European Commission working together on in a voluntary network to share solutions and guidelines. And there was a subgroup, two subgroups actually, preparing the discussion and checking out what can we do with COVID and things. And then there was a very emotional, big debate. Should we pick up this topic politically right now? So that was before Christmas or so. And some countries said, yes, go for it. We want to have a technical solution on a European level. And other countries said, well, maybe not yet. But of course, technology needs some time. So we already started to, with support from many people who are active in HL7 also, we started to develop some ideas what could be done. And eventually in January, the eHealth network accepted part of that work, and that was only focusing for now on the medical purposes. So that's the basic interoperability elements, minimum data set, trust framework, and these kind of things. That was published, and you can Google it and download it. But still, we are working, and this becomes more active right now. We are also working on this other idea: how can this information also be used in a secure way and safe for the patient? And with GDPR and everything, data protection, privacy. So we're preparing the technology that, if policy follows in that direction, that we have something that we can offer on a European level. And I'm involved in one of those subgroups. That's why I'm speaking with we. So that was my head with the European, my European work on. And then I can also report similar things are going on internationally with the WHO, the World Health Organization. There was a call for experts, and also we can see many HL7 people in there as experts, and there is a close collaboration also with the EU activities. But this is still under, well, also the EHN work and the WHO work is still kind of confidential, because it's a sensitive topic politically. So that's why you may not hear that many details on those ongoing activities here. Next slide, please. So now passing on to the country presentations, I really have some slides here which just show the void to fill by this meeting here. So maybe we can learn from some of the 22 European affiliates. We can hear something on the role of standards. We can understand what is the role of those affiliates in the standardization process in their country. This is very different, I think. And next slide, please. And then also the question is, what's the contribution? What can the affiliates contribute? What value do they deliver? And these are just 3 topics, and there may be more during the discussions. How can we create collaborations with other groups? What's so special about HL7 in terms of decision making? How do we do that in our country? And also vendor engagement, building the bridge from the government political decisions to those who in the end implement the solutions. That's an important thing to look at. So without further ado, I would say we can start with the presentations. So I will not introduce every one of you, so maybe you can just say a few quick sentences yourself to save some time. So we start, ladies first, with Line.
Thank you, Christoph. My name is Line Sele, and I'm the chair of HL7 Norway. I also work for the National Institute of Public Health. I'm also at the board of HL7 Europe. I'm here today because I'm working on vaccine proof in Norway, and we are looking into how to solve this on our side. In Norway, we are rather lucky because we have already our vaccine registry, or to be more correct, the immunization registry in place. Next slide, please. As you can see, there's been a mandatory registration of all vaccinations in Norway, and it started already back in 1976. And from 2009, all vaccines are registered into SYSVAC. Before 2009, it was basically the children's vaccines that were registered into SYSVAC. But now you can get an overview of all your vaccination. It's owned by the Norwegian Institute of Public Health, and we mostly share the data with proprietary standards for reporting from to the registries. It's reported from both the EHRs. We also have now SYSVAC.net, which is a net page where you can actually register the vaccinations going on with the COVID, for instance, because we needed some more possibilities for the primary care to establish a connection to SYSVAC. But there's already a lot of integrations to the registries from different sources that are actually at the vaccination point. Next slide, please. So together with SYSVAC, we also have the patient portal at helsenorge.no. There's where we can actually get our overview of our records in the EHR. And we can have several more services. We can also see our medications, etc. In Helsenorge, we also have a possibility to see what kind of registers we are mentioned in, or where we are actually part of. Among these, there are a SYSVAC. So you have already in Norway per day having a possibility to be printing out all your vaccinations in a paper. But it's not possible for only one vaccine. So you will get an overview of all vaccines or the yellow vaccine certificate for yellow fever. So next slide. So I'm going to show you how it looks today. I'm going to be honest, this is mine. So I've had different type of immunization, and this is the certificate that I can get today. So as you can see, it's not, it doesn't have all the data that the eHealth network requires or are asking for. And if we go to the next slide, you can see that the Department of Health has asked the National Institute of Public Health and Norsk Helsenett and the Directorate of eHealth to respond to the demands of vaccine proof. So we have now come up with a plan of how to actually do the work that requires to adjusting to the EU guidelines, which we call the eHealth Networks guidelines, as a step one. And we also include a digital solution as a suggested step one, where we actually use what we have and making it a little bit more printable or showable for COVID alone. Next slide, please. So I've searched a lot to find out what's going on internationally, and we don't actually have any standards for what to share and how to share it. We're talking about trust framework, and we have also the guidelines as what kind of data should be in a certificate, but should all those data be shared? And that's something we have discussed a lot in the startup in Norway, because included in the guidelines, there is also personal information. And the level of trust has been a lot of discussions around that in Norway, because if you do have, for instance, a verification of the certificate based on the UVCI, which is the idea suggested by the EU guidelines, then would that be sufficient to prove that you have been really vaccinated, or is that something that you have copied from someone else? So we actually have the police department as a part of this project, and then they have spoken a lot about the level of trust concerning border checks. And we have had quite a lot of discussions, because we don't want to use the registry where we have all the information about all the immunization. We don't want to use that as a public source for gathering validation. So we actually might have to make another registry to actually handle the different factors concerning validation. It's very important that we keep the trust that we have from our patients and populations according to our registries in Norway. So opening them up completely is not an option. Next slide, please. So this is copied from the WHO position, where they have an interim position paper. And I think everyone can go in and read this whole thing. I'm not going to read all of it, but there are still, at the present time, they recommend that we should not introduce requirements for proof of vaccination. And that's important things to actually know, that WHO are hesitant to actually have this kind of vaccination proof. But still, we are all following the private sector's pressure into getting there. So next slide. So I actually listed some of the considerations that we should have, because there are so many groups that cannot be vaccinated or won't be vaccinated at any point. There are people that are allergic to vaccines that cannot be vaccinated. We have a lot of kids below 18 that cannot be vaccinated according to the rules that are now. And we have also been approached by people who want the right to choose whether to be vaccinated or not. And we do have a lot of countries that might not be able to vaccinate all of the populations and cannot afford it. So should we leave them out? Or should we just kind of make sure that the private sector doesn't rule the whole thing and doesn't share too much data of the healthcare side? But we also need to open up the society, because we all share the burden of having a closed society. And I think no one would disagree that we need to open up more. Next slide, please. So there's also the question about volunteer versus the pressure. So when is it volunteer to show your health care data, and when is it the pressure? When do we start to actually have a vaccination card in order to keeping your job? Or is it just going to a concert, which is voluntarily going to a concert or not? Or are you able to travel to see your grandmother across some other country? In order to actually get there, you need a vaccine. So yeah, next slide. So my point in the end here will be that we need proof of more than just vaccination. We also need proof of immunization and testing to be able to be shared across the border in a safe and also trustworthy way. Thank you. That was my last slide, and I give the word to next. And Christoph, I don't remember the next one.
Yeah, so Giorgio is next. Thank you.
Thank you,
I suggest that we have some questions in the chat, but they are not directly addressing Norway, so maybe we keep them for the discussion.
Okay.
Giorgio, go ahead.
Okay. Oh, thank you. So let me introduce myself. I'm Giorgio Cangeli. As written, I'm chair of HL7 Italy, and I've engaged in HL7 Europe as technical lead. I have also other role in HL7, and I am with other friend of the HL7 community involved in the WHO work group for the vaccination certificate. Next slide. I'm here trying to present a little bit the situation in Italy, and it's not so easy because the organization of healthcare in Italy is operationalized at the regional level, meaning that we have policies, projects funded national level, but the responsibility to make these policies in practice is at the regional level. So you should imagine that we have a sort of 21 different health systems and potentially different EHR system and registries. Even if with the COVID, the balance between the central part and the region change a little bit. Next slide. So I'm not going to present what is happening, try to describe what is happening in different regions. Let me try to provide you an example of what is happening in my region, Tuscany. As a citizen in Tuscany can access its own portal and see a sort of chronological view of what is happening, what are, for example, the prescription that receive, what are the access to the hospital, a lot of other events. And beside the other event, also vaccination. This is the case of vaccination received at the beginning of February this year. And as you can see, you can have a set of data that are collected in the regional registry, like the type of vaccine, the product that has been used, the lot number, what is the next dose due, the site, what is the if it is the first or the second dose, and the sub-organization. Let's say in the figure is the yellow one that around Florence, that is responsible for that vaccination. Next slide. As a citizen, I can also have a view of the vaccine, not in chronological way, but in a different way, to also access and show the vaccination that I have through the mobile. Next one. Through the portal, I, as a citizen, I could also, this is not my vaccination card, but this is a real vaccination card. As a citizen, I also ask the portal to generate a summary of all my vaccination. And so you have the last one of a few days ago about COVID, since the first one at the very beginning. And as you can see, the first one, there are missing information because the establishment of a regional registry is quite recent. And so they have recollected all the information, the paper information and information that were managed at the sub-regional level into the regional registry. Next one. So, and as I told, this different region may have different capability, offer different services, but there are some common ground. At the national level, we have a national vaccination registry that is established in September 2018 with their own technical and functional specification. And then we have a different infrastructure project that is also called Fascicolo Sanitario Elettronico. That is a project that tries to assure the capability of sharing data and document across the different region. And for that one, there is a result made from a group to try to define the content of a single vaccination event and of a summary of immunization. Next slide. So for what concerns the national registry, the national registry defines the minimal set of data that each regional registry shall support, because these are the data that are also used to send information, depending on the type of event, to the national registry. However, by law, this registry should only disclose anonymized and aggregated data. So it has mainly a purpose of monitoring the thing, rather than in principle to manage the, let's say, the clinical part of the information around the vaccination. However, as I told, there are the communication between region and the national is bidirectional, because it's true that the region need to provide every quarterly the vaccination provide, but when you move from a region to another, you have 20 days to send information to the central repository, so that the central registry, and then the central registry send this information to the other region. So this is the way, if you move from one region to the other, you preserve your information about the vaccination. And the same happens if, as a citizen of Tuscany, I go to another region to have the vaccination. In that case, that region send my vaccination event to the central registry, and there is 10 days to inform my region that I received a vaccination in another region. For the COVID, the rules are different. Each region need to send the information to the central registry by the end of the day. For what concerns, next slide. This is the national registry. Then, as I told, there is the national EHR system that was initially conceived for sharing data and document. For the time being, it supports the exchange of clinical document. The document are CDA List 2, and that work made by that group defined two different type of events that are documented: the single vaccination event and the vaccination summary. That is the sort of vaccination certificate. Next one. What happened is that that paper include a data set, and from that data set, and include the data set and also a proposal for a CDA representation. And currently this specification has been moved under HL7 Italy, and there are this month under ballot in order to collect feedback and input and suggestion from the HL7 community. Next one. Just to give a quick look to the data set, as you can imagine, we have some information about the subject, some metadata of the certificate, and the list of vaccination, those that has been administered and those that have not been administered. Next one. Let me skip the subject data. For the metadata, we have the creation date, who is the attester, who and when, and the sub-regional organization that is responsible for that certificate. Next one. I hope is no, okay. The previous one, yeah. Thank you. For the vaccination, the required information are the target disease, because as you can, if you have seen in the certificate, they are organized per target disease. The summary not organized per product, per vaccination event. You have the date when it happened, the type of vaccine, the dose number, and the performer. I put a yellow mark because about the type of vaccine, I think that there are some further investigation to better understand how these align with the European similar concept, and also between the fascicolo and the national registry. Next one. So for the optional information, you have information about the product, the annotated site, reaction, next dose, reaction to vaccination, and location. Next one. And for the vaccination not given, these are collected for target disease. One, this refusal or the fact that the vaccination has been postponed is recorded, the reason for not giving, and also when is the due date if the vaccination has been just postponed for any reason. So the expected day when it is expected you come back to have the vaccination. Next one. So just to conclude, these are just personal consideration. As I told, the specification for the fascicles, so those based on the CA, because that of the national registry are non-standard XML services for exchange this information. This is ballot, is not yet implemented, and I think there are space for refinement. I think that maybe a better understanding of the synergy and of the overlap between the national registry and the fascicolo might be useful, either in terms of functional specification and also in terms of the mechanisms used to exchange this data, also in terms of data set. We need to further analyze and to what is the mapping and the coverage with the ongoing European WHO core data set, and also the intent is to try to keep the European, the national, and the WHO initiative and to contribute to the ISO 5384, that is the ongoing work on the structure and data for exchange of immunization data. As I told, the current specs are for the CDA, and I think that if we would like to give better services and also to be more aligned with the direction that the WHO and the European proof of vaccination certificate are following that direction, maybe to consider an extension or the transition to the FHIR representation of this data. But as I told, these are just my personal consideration. Maybe others can disagree on that. Thank you.
Yeah, thank you, Giorgio. Just to bring up one suggestion from the attendees, some people are really interested how open those systems are for external integration, for retrieval of whatever, depends on the case, personal data, demonstrating proof. How can this link to a framework where other companies could offer services? So maybe maybe Georgia can quickly answer, and the other panelists can also maybe pick that up.
Okay, this is a very challenging question because we had several times a lot of discussion about from the companies that complain about the openness of this regional system by external services. Because I can access, let me talk about what I just shown. I can access with the app that my region gave me, but I'm not aware, let's say in that way, about other private systems that can, under specific agreement, access this data. This is different on what is happening in other country or in other region, not in Italy, in which you have a certification mechanism for app that allow you to connect under certain condition through API to the regional system.
Okay, so no unique solution so far in Italy. So in the consideration of time, we move on and we move to Switzerland. Roland Lux.
Hi, ich bin Roland Laux. I'm chair of HL7 Switzerland, and I was an employee in the company RPage, which was involved or is involved in the platform I will show in the next slides. Next slide, please. Yeah, we have in Switzerland, we have a Swiss vaccination patient record. We have also an electronic patient record now evolved in Switzerland, but the vaccination record was separately done. Next slide, please. We have a web-based platform which has two interfaces, for the one for the patient because it's important. It's for the patient because he has his electronic vaccination record and his vaccination certificate there to take it with himself. We have a mobile app where it's on, and we have also the paper you can print out where everything is on in official design of Switzerland. It's already online since 2011. We have behind it a very, very good and extended CDSS system for the vaccinations, where the vaccination plan of Switzerland, which is done by an expert group of the government, is inside, where you can validate your vaccinations and see your vaccination status. We have in a moment 370,000, I think, records now inside. We have 12,000 healthcare professionals registered in the system, and more or less 4 million vaccination entries. If you see these numbers in comparison to 8.5 million people in Switzerland, we are not nowhere, but it's free for patients and it's free for healthcare professionals. And since the vaccinations are announced in Switzerland for COVID, we have an increase from around 150 new registration for records to 1,000 per day. So it's a quite big increase now, where the people detected the electronic version, because a lot of people don't know how it's in other countries in the world and in Europe. Oh, I have to be vaccinated. Oh, where is my vaccination card? Oh, I've forgotten. I lost it. Therefore, it's a big use to have this system. Next slide, please. As I told, it's a private initiative from Erste-Kasse, RPage, and ViaVac, 3 companies, which set up the foundation Meine Impfungen in the year 2015. We have the expert, Professor Medical Dr. Claire Ann Sigrist. She is a really expert in vaccinology. She is working at the University of Geneva in a hospital. She is also in the committee of the immunization staff, which make the immunization plan. She is also in the advisory group of experts from the World Health Organization. She was involved also in testing and development of the Ebola vaccination. and she is for sure the president of the foundation board. So she is also the head behind the CDSS system, which is delivered by the VIAVAC company, which is integrated in the platform. In meantime, the system is also, and the development is also supported really by the Federal Health Organization for Public Health. But in principle, the financing of the development and running the system is on private foundation base. Next slide, please. A short overview of the architecture. We have the central record stuff. We have the CDS system behind it with the recommendations, national base. We have for sure some interfaces to proprietary systems. We have an FHIR on standard trial use version 3 interface. And we have an IHE XDS CDA interface where we also exchange the PDF of the shown certificate. And for sure, we have the UI. That's more or less how it's built up. In meantime, with COVID, we have also the complete attachment of the different regions. It's like in Italy, we have 26 regions in Switzerland who are responsible for the healthcare. From the government side, it's not so easy. You have to make contracts with all these 26 regions to have now this complete COVID vaccination systems attached to this system to have it electronically. But it's still on optional in base, so people can decide. If I get vaccinated for COVID, I can decide, oh, I'd like to have the electronic record, or no, I don't want to have this electronic online. An additional service is delivered by medical students of the University of Geneva, so people can scan their paper cards and adding it to the system, and then for 10 francs, the cards will be digitalized, transcribed to the electronic version in the system. It's also a big benefit. It's quite cheap to do some such things, and so you have your electronic vaccination record with you. Next slide, please. Yeah, as I announced, we have two interfaces working with standards, with CDA and also with FHIR. Next slide, please. We have in 2016, we had the first version CDA on the Swiss realm specification based on CDA1, I suppose, designed. Later on, it was transferred to the Art Decor for modeling. Since last year, we have version 2.1 from this exchange format and CDA based on release 2. It's also an Art Decor modeled. And now I was making the implementation guide of the FHIR release 4 for vaccine record document exchange. You have here the URLs behind in the slides to see where we're going on. This implementation guide is actually in informative ballot phase now. It's going on for requests, and the mapping is in development between FHIR and CDA. We have in Switzerland also made a FHIR core base, and this implementation guide for vaccination is for sure made on the core base. In principle, the CDA and the FHIR stuff is on the governance from eHealth Swiss. eHealth Swiss is a government-near organization to coordinate the 26 regions in Switzerland in the eHealth environment. But eHealth Swiss is member of HL7 Switzerland, and we are near working together, and yeah, and we have not so much experts in Switzerland to do the work, so we are a close group together. We go also with IHE Switzerland to build up a good standardization platform for all development companies and organizations to reach a good digitalization in the future. Next slide. For the CDA and the FIRE format, the actual versions, we have 5 different types defined. We have the immunization administration, so that is an immunization event. So you can add in a CDA or in a FIRE document 1 immunization or 3 immunizations and load it up to the system. The second one is the immunization certificate. I will show a little bit more in detail afterwards. The third one is the vaccination record. That is a complete data set we have in the system, which is online. Not only the vaccinations, we have also the medical risks, the explanation risks, some allergy and incompatibility stuff the inside, which will all go to the CDSS system to have really the correct from medical point of view, correct immunization recommendations. And the fourth and the fifth one are with recommendations, so the recommendation request and response to a CDSS system defined. This is special because these requests are pseudonymized, so patient information and healthcare professional information are reduced to a small amount of data. In example, the postcode for the address of the patient. Next slide. Go a little bit deeper in this. I have always 2 pictures, should be more or less the same content. One is CDA, one is FIRE. We have for administration, we have patient, practitioner, organization definitions as normal. It is done in a bundle, and afterwards we have sections with the immunization entries, also applied immunization of the vaccines. Next slide. The immunization certificate seems more or less the same, but there are also the immunization entries in which are applied, but also the patient can say in the system, oh, for some vaccinations I don't like it, so please, I will not be vaccinated for this. And this will be also an entry in this certificate. Next slide. Then the vaccination records themselves, like I told you, immunization entries are inside undergone illnesses for immunization, like measles or so. List of problems, medical and exposition risks, like I'm soldier or I'm working in a hospital or working with old people. This you can checkbox it, and then you will see what is coming out for recommendations. We have allergies, intolerances. We have also a laboratory serology section if you make laboratory checks for immunization. We have also pregnancy inside, so if a woman is pregnant, she can enter also the delivery date, the think delivery date in the future. So the system will respect this in the recommendations. And the recommendations, if they are calculated, are also in the record. Okay, next slide. The immunization recommendation request is more or less the same like the record, except the recommendations. You enter all this information into the CDS system, and you can become back the response where you have the recommendations inside. So these 3 are more or less the same, except of the person data, which are pseudonymized. Okay, the next slide, please. Now the response, next slide, please. We can go over this. I've forgotten to tell, patients can also add immunizations inside, vaccinations inside the system, but only the validated by healthcare professionals will be printed out on a certificate. But you can also print out a list of all received vaccines, and there is also marked it's not validated by a healthcare professional. The transcribed data by the service in the University of Geneva will be validated as healthcare professionals. Yes, this is this. Yeah, on the final, I will tell Austria adopted the CDA for their e-health records upon Swiss specifications. They made not exactly the same 5 document types, but they came to us and heard about our system, what we have done. The next one of the next things are the discussions how we will transfer this data between the vaccination record and the electronic patient record, which is now evolving in Switzerland. And for sure, the next will be the FHIR API changed to release 4. On this, on the end, I will thank to all these people who were working behind this whole story, to have this electronic vaccination record, to have the specifications, to have the endurance to go through a lot of complications and discussions also with the government. And yeah, it's a lucky story in principle for the patients, but there are also some pitfalls. Thank you.
Thank you, Roland, for the deep dive and some details how to use FHIR also as an equivalent to CDA. That's I think remarkable, and looking forward to the FHIR API and your experiences with that. We are a bit behind schedule now, so if I now switch to the FHIR work of the whole portfolio of other countries, maybe you can try to stick with something like 4 minutes, maximum 5 with your presentation, so that we have some time for the discussion. I pass on to José from Belgium.
Hi everyone. Indeed, I'll keep it short. So I would like to relate to some of the problems that the colleagues have had and explain how we have implemented what we have in Belgium. So I'll explain briefly what we have. We don't have a full range of solutions targeting, for example, the vaccination certificate at this moment. There's a couple of reasons for that. And I would like to start by showing the interoperability scene in Belgium. So next slide, please. One thing that has been influential for our work is that Belgium is a federal state, so it has several regions. Regions have their languages, regions have their responsibilities. So the collaboration between regions is fundamental, and of course, given different perspectives, given different goals, sometimes there's different priorities, which is of course the case, and creates complications. So at this moment, the vaccinations are kept in a regional vault. So each region has their own vault. So we have the Flemish region, so the main region is Flemish region and Wallonian region. Brussels also is another region and also has their vault. So the vaccination for each of the citizens is stored in the person's residence vault. So if I live in Flanders, then my vaccination record will be in my vault. This provides us our requirements, what we have to handle until now. So until now, it was the typical thing that my colleagues have already mentioned. We just have to store the vaccines because people go to school, they get vaccines. People go to travel, they get vaccines. People need to sometimes to register an accidental vaccine when there's an accident, etc. They might get a reinforcement. This is the normal stuff. Of course, the situation changed 1 year ago. But until then, in Belgium, we have been relying on one federal standard. It's called CMER, and it's similar to CDA. So it's a XML-based infrastructure. And the fact that we already have a working standard, it means that we have to pay attention to what we are doing next if we're going to do something on fire. So fire is now starting since 2019. We are ramping up the adoption of fire. It means that we have to pay attention to compatibility. We don't want to lose all the vaccination data that we had before. We don't want to lose the interoperability between vaults, and we don't want to force too much the push for one or another technology, because one vault in one region might have preferences to do this year or that year. So we have to pay a lot of attention to compatibility between solutions. So when we adopted fire, we started by having it driven by projects. So the projects can be driven by community or government, and there is a path for official publication. So the fire specifications are always on target to become federal standards. So the work that we are doing in HL7 Belgium with the communities and with the government, this required us to define a process, so an operating model and a standardization roadmap for us to reach our goal, which is if we define something as a national standard, it should become a legal standard in Belgium. So we have set up that infrastructure, and that is relevant because, and if you go to the next slide, we wanted to do the vaccination. So one of the things that we wanted to do is the vaccination. The Belgian fire vaccination profiles were started and finished during 2020. So one of the projects that we had from one governmental institution was we want to start improving the way that we capture vaccines. So this was very early 2020, and we thought that there was a distant flu somewhere that maybe eventually will have some operational impact in Europe, but let's keep doing business as usual. So let's focus on the children, because that's what we are focusing on, what we have been focusing on for the last decades. So we started that. The vaccination profiles on fire, they were finished rather early. The Belgian standard already existed for the Khmer standard, so the vaults already support the exchange of vaccination information, and this meant that as we got through the pandemic, there was a political decision to not force a fire transition during the pandemic, which, as a technical guy, I might wish it were somewhere else, but as a citizen, I'm actually happy, because it means that the technical solution can be there, but the main thing is this going to cause a negative impact or causing harm to the people that are on the field, so the people that have to vaccinate, etc. So we decided to keep the working infrastructure. If on the side something else can work, that's still the free spinning wheel that we have for fire, that's fine. But there was no decision not to force the fire adoption during the pandemic. And so that allowed us to thank you. So that allowed us to work in our consistent way. And I just mentioned this briefly to share how we addressed the biggest problems that we had. So the biggest problems here are not whether this standard or that standard supports vaccination. The biggest challenges that I had seen in Belgium, and I now also confirm with my colleagues, is the functional discussions. So what are we going to do with the data? Which data do we need? Can we share that data? And if we share that data, what's happening? So if I share my data because I need to cross the borders, or if I want to have a barcode because I need to go to the dentist, or to the bar, or to the restaurant, what happens with that data? Am I sharing the right amount of data? Do I have GDPR permissions to share that data? Does that person that get my data, is that person mandated to some sort of care for my data, for protecting my data as well? And how do we enforce it? So those were all the discussions. We had discussions about data minimization, as Roland was saying. We had discussions about who can access which data. So that discussion happened, and the first thing that we did was to start with the functionality. So Sadhana, if you look at the next slide, please. The first thing that we did was to define what is our model. So we defined our use case, and our use case was we focused on the immunization event. So at this moment we are not, so our profiles in Belgium, they don't focus on the vaccination certificate. That's another use case. The use case is the nurse has a child in front of them and they vaccinate the child. What do we want to capture from there, and where does the information go? So there was a lot of discussions around the data that we needed, and that we started by having a more abstract model. So we started by having a logical model, which is part of our procedure, because it really facilitates that we have these discussions with the functional experts, not with the technical people, because they are the ones that decide, can I share this data, yes or no? Is this data okay, or does this data require a code? Which codes do we want there? Do we want to put the national product code? Do we want to have another code for the products? All of these things, they are functional discussions, and if we don't settle them functionally, then the interoperability on the technical side might seem easy, but we're just postponing the problems that we have to make things work. So we had the logical model, we made it work. I mean, we validated the model by saying these are the use cases. This is what we have. So we ended up with one profile. I think if you click once, you will see the profile on the right as well. It's just to show what we had. Yeah. Oh, sorry. Go back. Maybe my mistake. Yeah. So we don't have to zoom in, but we had a couple of extensions added to fire, the normal thing. So we added a couple of flags, a couple of bindings. So we ended up with one profile, 4 extensions, 4 value sets, and the corresponding coding systems, some naming systems, and many, many examples. That's the thing that we did for validating our scope just for the immunization event. If and when we look at the vaccination certificate, we will most likely do the same thing. We'll force people to agree on a functional level as much as possible, and then we'll validate that with examples, and then we will certify the technical solution. So this is what we did on vaccination. There's an outcome to this, but before that, if you go to the next slide, please. On the vaccination certificate, there is no standardization effort at this moment. Vaccination certification, as in many countries, was already required for some activities like schools, and this is a self-issued declaration. So for example, as a parent, you have to go to your city hall and declare that my child has the right to go to school because here is my declaration that this person is vaccinated. There is maybe somewhat interoperability opportunities there, but it also reinforces a bit of the how do you say, the civil responsibility aspect for this, because you're saying I certify that this person has this, which in the case of people of migrants, then it also allows us to lighten the load a bit on the interoperability and not wait for the European-wide interoperability before a child can go to school. So this is the situation that we have there. The only way that we have digital interoperability at this moment in Belgium is by the patient's summary, which is based on the Belgian standard. So if I want to see the person's vaccination record, I have to see that person's summary. That is sufficient for internal purposes, for the purposes until now. I will tell what we will do in the vaccination certificate. And finally, to wrap up, so what we did and the method that we used, because we anticipated lots of the functional discussions, and because we could have a clear language, so it was a technically uncontaminated language, that we say, do we need to use the national product code, or do we need to use the ATC codes for the vaccinations? Do we look at the code for the vaccine as something different than the code from the disease, or are those the same thing and they are corresponding? So those questions we had, and it was easy to discuss it with physicians, with people from more administrative roles, and people representing from the community and from the government. These discussions became easy, and that's why, and for the next slide and my final slide, we could start some collaboration. So because there was no pressure in Belgium to do something, we just used that opportunity to say, hey, we have this, we have done this process, we had some good conclusions. So we started with IHE International to say, maybe we should start some international discussions to see. We did that. So what does the Netherlands have, and what does France have? And we started some discussion within IHE International. So it's just a starting project at this moment. At the same time, a few weeks ago, 1 month and a half maybe, we had some discussions with another working group in HL7. So maybe this would be a Gemini project. So it's just a way to have people around the table and say, this is what these people have in terms of content. So whatever we did, if it helps the community, it benefits not only the community but ourselves, because we can validate our approach. So the vaccination approach, what we have is on the right track, meaning that we are now in public comment phase for approving it as a federal standard. It should be published by March, so it will become a federal specification by March. The vaccination registration framework, so the profiles, the vaccination certificate. We are, in that case, we are lucky that we can wait for all the others to do the good things and make some mistakes, and then we'll learn from those good things and those mistakes as we go. So that's the advantage of not being the first in some things. So that's good. And this is what we have. So we don't have the vaccination certificate yet. We have the data that we need for that. We have started discussions, and we have the logical models that support us, so that when we say, can this data be shared with a restaurant owner or etc., we can have those discussions on the functional level and on the policy level, and not being driven to immense technical discussions, because that will be much harder to get a consensus on. That's what I have. Thank you very much.
Thank you very much for the deep insights, and also especially for the collaboration and cooperation part. I'm sorry, I have to ask presenters just to be a little bit shorter, because otherwise we will not make it to the discussion. We continue with Denmark.
Sure, thanks, Christoph. I'll see what I can do to shorten my presentation. My name is Jens Willersen. I'm the chair of HL7 Denmark, and I'm the member, one of the members of the HL7 EU board of directors, together with Christoph and Line Selle. And I'll give you a short introduction to what the situation is like in Denmark. So, even though the media and the ministry of well, the officials in Denmark have stated in the media that we should have a technical solution almost ready for implementation in the end of February. That is currently not the case, at least not one that is digital verifiable. The case is currently in Denmark that there is a preparation of how the digital COVID vaccination certificate, passport, whatever you want to call it, that is in the preparation phase. Probably there's going to be some announcement of it within the next couple of weeks. Currently, we have a paper version that exists that any citizen can log in to the national portal and print out if they're vaccinated. And the same goes for tests. Unlike the situation in Belgium and Italy, Denmark is it's a small, very homogeneous country with a lot of centralized services. We have one central repository for all medication, one central repository or vault for vaccinations and medications. So this is a bit different from what you have heard so far. We are a lot of vendors in Denmark. I myself work at one of the vendors of supplying healthcare services or digital healthcare services. We are a lot of vendors looking and waiting for seeing when the information is going to be disclosed on the topic of how this digital passport is going to look like, or what is wanted. And of course, there's a lot of debate on the ethical and the moral side that Line was also into in regards to what if you can't be vaccinated and so on, and do you start to differentiate between people. We expect that QR codes, which has had a lot of debate, what QR codes can be used to, and if the WHO is looking into it, and same with the EU Commission. But we suspect that it will be part of the digital solution. So next slide, please. So State of the Union in Denmark in terms of healthcare information standardization, which basically is what this meeting is all about. Historically, there's been really not that much use of HL7 and IHE standards in Denmark, really. Denmark is a small country, and we have used bespoke, custom, national standards, and somehow it has tied the country really tight together. Everything actually works. It's just not following international standards. CDA and ITXDS infrastructure has been or was introduced a couple of years back. It is not widespreadly used for the main part of information, healthcare information flowing across the country. It is starting to be used for sharing really document kind of things, but I don't believe we have much more than 5 different CDA profile documents. HL7 files, that is like a whole other story. That actually has no national or directly regional use so far. We are a system, I myself is working on is actually a pseudo-national system, because it's going to be used by all regions and municipalities, but it's not actually a nationally endorsed solution. But, well, we have all the information flowing in Denmark, actually. And over custom standards. And this probably points into, or a conclusion of this would be that the first version of the digital passport will probably not be backed by international standards. I can only hope that would be the case, but I wouldn't get my hopes up. Let me see it like that. At least not the first iteration, but I believe we could quickly adapt any national or internationally ratified or established standard pretty quickly if we wanted to. Next slide, please. So technically in Denmark, it's actually a pretty easy task. As I mentioned, we've had a central repository for all medication, all vaccination, at least since nationally widespread use. Everyone is obligated to use this service, so we have it all shared, and all citizens can access their own medication and their vaccination information. And the same goes for all practitioners regarding GP, primary sector, secondary sector, and so on. Even elderly home care facilities can access this. The vaccine information, since it's already in place in central repositories and registries, is actually already accessible, also digitally. So you can get your vaccine information going into the national portal called Sundhed.dk, or you can actually download the national app. It's called My Doctor in English, which makes any Danish citizens it makes any citizen possible to access his or her GP information, which is where and that's the way that you can get your vaccination info. But none of this information is actually built upon international standards. At least 98% of it. Last slide, please. And what you see here is, the information is actually accessible. And what you see here is the screen dump I made yesterday. What you see on the left is our national portal. Works up and running. You can actually go in there, and they've made this special feature that you can print out a vaccine passport if you actually are vaccinated. I just logged in during the presentation to see if I could get one. I'm not vaccinated, and of course I couldn't. What you see on the right side is actually screen dumps I made yesterday evening. It only lists my completed vaccinations, and I can see it's, so I've been given someone as a child, but I guess they have not been loaded up. So what you actually see on the right side is my direct access at any time to my vaccinations, and the only one that I've only apparently have is the tetanus vaccination. So basically, bottom line is, if the Danish society and the Danish officials would like to get a vaccination passport out, it's not that hard, actually, because all the information is already out there, and making a QR code, for instance, out of any of that and then digitally sign it, that's a no-brainer and actually not that big a task. That concludes my presentation.
Thank you, Jens. So a country with an HL7 affiliate that does not yet use HL7 widely, also interesting. Big challenge for you probably, Jens. Quick look to Finland, Mikael.
Right, thank you, Mikael Rinatmäki. And my role in HL7 Finland is Fire Ambassador, so kind of an evangelist of interoperability here. Next slide, please. Yes. So in Finland, it's all based on this Kanta service, actually services. It includes patient data repository, patient portal, prescription service, and pharmaceutical database. And the basis of that was built in Northeast, so the first decade of this millennium, and it was already based on CDA. And we have 4 different systems in healthcare. We have the public and private healthcare and occupational healthcare as separate, and then student healthcare. And especially the public healthcare is spread across regions. So the original purpose of this Kanta service was to be a patient archive, so information archive. Then it evolved into a near real-time health information exchange between all these different players in healthcare. And now it's becoming even more operational. And the latest addition to Kanta services is the personal health record. And that in Finland means the patient-generated health data. So all the data that we get from our activity trackers and sleep and wellness monitors and these kind of apps. And only that part is based on FHIR. Next slide, please. So a vaccination certificate is being prepared, and that is driven by the Ministry of Social Affairs and Health. Not going to read through that. You can access the slides through the handout in the control panel. So in interest of time, let's go to the next one. So they are building a certificate that you can access your data as paper or in electronic format. And that is implemented by public sector bodies. So there's Institute for Health and Welfare, and that organization is controlled by the Ministry of Social Affairs and Health, and they are really driving this. And HL7 Finland has not been directly involved, but DHL is a member of Finland, HL7 Finland. And there are some challenges. So since the system is so old and ancient, the EHRs connected to that may talk with some dialects of CDA that are not structured enough to contain all the finesse of vaccinations. So you may need to search for that data from the textual format. And that is something that is currently under work. So DHL will guide the providers and also support the system vendors to implement that. And some feedback from DHL is that they are, of course, following the World Health Organization activities and would like to be more involved in order to avoid doing duplicate stuff. And also some other information. So there are already public healthcare providers and private healthcare providers who are coming up with their own solutions for certification, vaccination certifications. So the most recent one was from HUS, the big public healthcare provider, and they launched a service. So if you have been vaccinated by them, you can go to their website and download a certificate out of that. So plenty of different activities popping up, uncoordinated, because everybody just needs to be fast. I guess I was fast as well. That was my brief outlook from Finland. Thank you.
Yeah, great. Too fast for me to unmute. Thank you very much, Mikael. Moving on to France. Thierry, hello.
Thank you. Hello. Good morning. I'm Thierry Dart. I'm working for a government agency, ANS. ANS is a French agency for e-health, and we are affiliated to Health Level 7 International on Health Level 7 France. And thank you for the slide. Yeah, since 2010, we have in France a national personal health record, so a patient-centric health record called DMP, and technically it's a national document repository using XDS specification standardization, and we are using CDA document in this repository. More than 200 software or system can have an access to this national XDS repository. Next slide, please. Yeah, thank you. So we are the Ministry of Social Affairs and Health is preparing the introduction of a digital vaccination card, and that's a small part of a more big program named My Health 2022. So we have produced a national extension of EHE immunization content for CDA, and we have made our first project-a-thon in November 2020. So it's very new for us. Just with this system, we have also a web portal where patients can put their vaccination, and if this web portal produces a CDA, and this CDA goes to the DMP, National XDS Repository. So the project is beginning. We have also a specific application for COVID vaccination. And we are planning to put a decision support system for immunization recommendation using a FHIR profile, but the project is just beginning for this decision system. So what can I say? Sorry, it's that the digital vaccination card in France is beginning. And of course, we are very interested for sharing experience and with our colleagues from HL7 from also other countries. Thank you very much.
Thank you very much, Thierry. Also interesting, again, CDA. So many people still doing CDA. This is notable because others just talk about FHIR. So we see it's on the market. So thank you very much. And we go on to Sylvia, who is chair of HL7 Germany. Sylvia, the floor is yours.
Yes, thank you, Christoph. My name is Sylvia. I am professor at Charité, and I work voluntarily at vaccination centers. Okay, I give you a short presentation about the situation in Germany, and so something about the vaccination certificate, which is right now analog, our clinical trial data set, our statistics with the Robert Koch Institute, and I think nobody talked about the pharmacovigilance. Okay, next slide. So our vaccination certificate is currently completely analog, and the proof of vaccination certificate on the right hand is also handed out on paper. And as you all can see, serious mistakes could happen as a result on the left-hand side. Can you see the mistake? Okay, next slide. So the vaccination certificate is already specified and will be made available in the coming months. So the value set also includes vaccination against corona, as you can see on the bottom. So there's a SNOMED code. Next slide. The vaccination certificate will be integrated into the upcoming patient record. We don't have an EHR, or just an EHR which is based on documents, IHE XDS. And so this report will be somehow part of our new EHR, which is based on FHIR. Next slide. And for statistical purposes, a vaccination data set is transmitted or should be transmitted to the Robert Koch Institute. It's something like the CDC for Germany, and this is done via a CSV, and this is planned to be made available as FHIR as well. So next one. So vaccination, of course, plays a major role in research. So therefore, there is a field for vaccination in our German research data set. This research data set is based on FHIR and uses SNOMED CT. We are members since 2 months, and LOINC and ICD-10 and ATC, and we are using mainly the ICERIC data set from the WHO to build up on our research clinical trials here in Germany, and we recently won a project in H2020, which is called Orchestra, and the GECKO data set, the German Corona Consensus data set, will be transferred to the European community, to Europe as well. So next slide. We can see some coding here in JSON, and you can find the vaccine product containing only severe acute respiratory syndrome coronavirus with SNOMED CT, and below you see the disease caused by SARS-CoV-2. And my last slide is about our side effect report, the incident reporting to the PI. This is our Federal Institute for Vaccines and Biomedicine, and we don't use HL7 here at all. Thank you.
Oh, thank you, Sylvia. So thank you for this insight also into secondary use of the vaccination data. This is a very, very interesting topic, of course. We move on to Poland. Roman.
Hello, everyone. My name is Roman Radomski. I'm chair of HL7 Poland. And my task today is to deliver, I guess, very short, very brief information about how the HL7 standards support the vaccination process against COVID-19. What is the current status in Poland? So what was the situation in our country before COVID-19? We had two major components of the entire landscape. First is the Polish National Implementation Guide for HL7 CDA, which is most important, I guess, most important specification for interoperability standards in Poland. We develop and gradually implement it since 2013. And today we have this specification consists of more than 270 CDA templates. One of them is immunization card entry. And this specification is, well, formally it is obligatory specification for all clinical documents in electronic form in Poland, but because not all document types, clinical document types, are obligatory to be managed, to be processed in electronic form, to be generated in electronic form, then I would say rather that this is a very strong recommendation that if you implement any kind, if you switch from paper clinical documents to electronic clinical documents, you should use our National Implementation Guide for CDA. The second component of this landscape is P1 platform. This is the central system based on HL7 CDA and HL7 Fire. And this is the central system developed by government, by our eHealth Center, which is an official eHealth agency for Poland. And major functionalities of this system is handling of selected documents like electronic prescription. Nowadays it covers almost 100 drug prescriptions and dispensation documents, drug dispensation documents all over Poland. And electronic referral, this is obligatory for just for selected types of referrals. Another part of P1 platform is registry of service events. This is now being implemented in HL7 Fire, being rolled out in Poland. Next slide, please. So even before the COVID-19 problem started, even before COVID-19 vaccination process started, the eHealth Center developed a central solution and rolled out that solution to support the vaccination process. And the most important part of this solution, of course, in respect of the COVID-19 vaccination immunization problem, is that the whole system is based on the P1 platform and web app application for practitioners. This is a central application. This is not in any way integrated with the local systems. This is web app application just developed just for accessing P1 platform for those practitioners, for those medical providers who cannot use their local systems to access P1 platform, which is of course possible and encouraged by eHealth Center. So for COVID-19 vaccination, this architecture works pretty well. I mean, all those vaccination sites are usually the small rooms in the whole medical provider facility where they can work without using their local systems. They can work just with the central application connecting to the P1 platform. And two major data objects being exchanged, being created during the process is electronic referral. This is the CDA conformant clinical document being created automatically by P1 platform. And on the basis of this electronic referral, of this clinical document in electronic form, users of web app application for practitioners, they perform the task during vaccination, and then the result of this process, this task, is immunization record, which is a FHIR conformant resource, FHIR resource that is being stored at the P1 platform. So this is the main concept, the main core of the whole concept. Next slide, please. So where the vaccination certificate is coming to this picture, to this diagram. When those both data objects, electronic referral and immunization record, where they are already in place, stored at P1 platform, then on the basis of those data objects, another objects are being created. For the electronic referral, it is created a PDF, well, image of the electronic referral, which is then published or which is made available for patients at the central portal for patients. And the same situation is with the immunization record, which is originally a FHIR resource. It is transformed to PDF format, and this is an actual vaccination certificate. This is the proper electronic document signed by electronic stamp that is made available for patients at the portal, and sometimes it is also sent by email to those people, to those citizens who have been vaccinated. Additionally, beside the vaccination certificate, there is another object. I call it vaccination proof, but that's just, well, you can call it vaccination proof. This is in the form of QR code, and this is offline QR code. So this is not a coded URL for some centrally stored resource. This is just a set of information which contains semi-anonymized data of the patient, which contains identifiers of the original FHIR resource stored at the P1 platform, and it has also some cryptographic measure to be verified, to be that makes the mobile applications possible, allow them to check, to verify this document. This mobile application for citizens, marked in yellow on this diagram, this is not a part of the system I'm describing now. This is already existing mobile application prepared by the government, and this is for identity confirmation, I would say. I mean, this is the existing application, and this application can also verify this QR code and to prove both the identity of the patient
and of the person and the vaccination proof delivered by the QR code. Next slide, please. So, as a summary of the whole concept, the solution now is used for all COVID vaccinations. So, from the very beginning of the vaccination program in Poland, circa 3 million vaccinations, 3 million jabs. All of those people, they have the vaccination certificates, they have the proper clinical documents in electronic form in the CDA conformant format, and they have the immunization record in the central platform in the form of the FHIR resource. What is important from our international perspective, I guess, is that we pretty clearly separated two layers of this problem. One layer is the clinically relevant records of the clinical information, and this is still in the safe area of the P1 platform. In this case, it is electronic referral and immunization record as a FHIR resource and CDA document. And on the basis of these clinical records, there is a possibility to create, I mean, this is routine procedure. It's not just a possibility, routine procedure to transform those data objects into PDF document and into QR code that play a role of the vaccination certificate. Both of them are verifiable. One is signed by electronic stamp, the vaccination certificate in the PDF format, and QR code has those cryptographic public-private key infrastructure-based method of verification of the vaccination proof. Thank you. That's all from me.
Thank you, Roman. Great insights on another system. So we're finally closing the round with a special guest today. Because why is he special? He's special in many ways, but the special thing today is that Ireland has vaccination and vaccination records, but it's not a member of, it doesn't have an HL7 affiliate in their country. So Eamon, the floor is yours.
Thank you. Thank you for the introduction, Christoph, and thank you for the spot to speak briefly about the Irish Smart Vaccination Certificate implementation. My name is Eamon Coyne. I'm working with the National Health Service, the Health Service Executive in Ireland for the past 16 or 17 years. I'm also heavily involved in European projects, and I've had the pleasure of working with Christoph on a number of those in the past and currently. Next slide, please. So traditionally in Ireland, in terms of the messaging exchange, it was HL7 2.4. To address the cross-border use cases, so the eHealth, the digital services infrastructure, the OpenNCP, MyHealth.eu, the exchange of patient summary and e-prescriptions underpinned by European Directive 2011/24/EU. When we were addressing those from the Irish perspective, what we done was we started to devise an architecture using the use case methodology. So in conjunction with HL7 Europe, what we started to do was to define those use cases from the Irish perspective. We started to then, from the use cases, we started to develop an architecture, the subsequent interoperability specifications, the testing tools. We have a Gazelle, a national test tool similar to the Swiss model, and what's done in the European in terms of the eHealth DSI, and we hosted national projectathons. So in this diagram here, we can see a horizontal backbone of data sharing capability, which is based on XDS, and the horizontal data sharing backbone will feed the clinical vertical systems, including the OpenNCP. So this data sharing infrastructure that we devised and have subsequently started to implement supports our Sláinte, our national strategy, eHealth strategy, and our national service plans. If you go to the next slide, please. So next slide, please. Yeah, thank you. So with the COVID-19 pandemic been impacting us all, we had to put up, we had no national IAS, so we had no national immunization information system. So we had to implement a system to support the rollout of the COVID-19 immunization nationally. But what we decided to do in the background to that to support the infrastructure and to support the smart vaccination certificate is that we extended the XDS-based architecture to create the smart vaccination certificate. In doing so, we would align to the EU eHealth network guidelines and down the tracks aligning to the WHO guidelines and requirements also. If you could go to the next slide, please. So in terms of the proof of vaccination of a service, this is just another representation of the infrastructure and the technical actors. So you can see the shaded grey box there in terms of the HSE, which is our health service infrastructure. We added the immunization repository in addition to the patient summary and prescription repository for those European cross-border exchange use cases that I mentioned earlier. We have the document repository, the document registry. We have PICS and PDQ in terms of the patient registry. We have identity access management with SAML and OIDC providers. Relying on the immunization repository, there is a new service capable of reading immunization records and producing the proof of vaccination based on those clinical immunization records. So the immunization records that we defined are based on the standard conformity HL7 CDA via XDS and XCA for continuity of care purposes available to the healthcare professionals in Ireland and Europe. So the proof of vaccination is also available for medical and non-medical purposes for citizens, healthcare professionals and other verifiers. So if I was just to give you a quick synopsis of the workflow that we designed in terms of CDA templates, when the patient registers for the inoculation, it creates a prescription order CDA template. When they present for one of one, one of two, two of two inoculations, or whatever the case may be, dependent on the brand, it creates a dispensation record. That subsequently updates the immunization record, and then based on the immunization record, we can create the smart vaccination certificate. When we designed this specification and this architecture and this workflow, we weren't just thinking of the COVID-19 immunization use case, we were thinking of the national immunization system that's going to be rolled out next year. If you go to the next slide, please. Thank you. So the vaccination proof is available via secure services capable of providing confirmation of vaccination. It's a dynamic service and relies on the clinical data inside that immunization repository that's shown on the screen. The service and the proof of vaccination is always available to a citizen and empowers them to manage whom has controlled access to the proof of vaccination. So the vaccinations are also there for medical purpose via the standard compliance for the healthcare professionals, as I mentioned earlier. So in the implementation, if we go to the next slide, please. Trying to be conscious of time. So in the proof of vaccination, when I'm talking about it gives the citizen control, we're currently implementing this. This is not in production now, just to state. But what it will give the citizen the capability is who has access to the smart vaccination certificate, how long the smart vaccination certificate that's generated is valid for, how many times the QR code can be scanned. So we have a mobile smart certificate representation, and we have the full smart certificate representation also. So the mobile versioning, the smaller one there with just the QR code, can just be generated on the fly for freedom of movement purposes. The full smart certificate, vaccination certificate, is aligned to the European Health Network guidelines in terms of continuity of care. In terms of how we render those, it's modeled on the HL7 Fire Release 4 resources. It's a self-contained bundle, collection of resources, embedded resources and references between them, and it is available as a structured XML, also as JSON for various representations via XML transformation. Although it uses various parameters and still standard compliant without posing any specific requirements to understand it. Example, it does not use any custom extensions. So the QR code is an image resolving in the URL where the unique vaccination certificate is available for verification. So the eHealth network guidelines that have been released, we know that there's two interoperability elements in that, which is the unique vaccination certificate identifier and the minimum data set. So the UVCI that we're implementing as part of the technical implementation is aligned to that, and also on our smart vaccination certificate we have the minimum data set, again aligned to the European eHealth network guidelines. So we're still heavy in implementation. We have quite aggressive deadlines to meet, but again, we took the approach to utilize the existing standards-based architecture, and in addressing the COVID-19 immunization use case, we've done so that when the citizen goes in, they won't be just looking for the smart vaccination certificate for their COVID-19 immunization. It can be for any number of immunization records going forward. So that's my last slide. I hope that was quick enough, Christoph, and I didn't take too much time, because I know you want to get to the last part, which is the Q&A session. And thank you once again for the time, and I hope it shed some light on our national implementation.
Cool, thank you. So also great standards work, and with a European view, that's definitely a big question. How can we move forward to align all those solutions? But before we get into the discussion, maybe the panelists will have some questions to each other, burning questions, just something that they couldn't, because we as panelists, we cannot really use the questions. All the other attendees can write questions and we try to answer them. But yeah, just speak up if the panelists have something burning to ask to each other.
No, just to say, Gora, my got on the last slide was Irish for thank you, in case you thought it was some gibberish. Semantics are important, Christoph, but no, I have no questions to my other panelists.
Thanks.
I do have a question. Why there is no HL7 Ireland?
I'm working on it.
Okay, good. Question for answer. That's good.
I feel like an imposter now.
Oh, that's cool. I mean, one of the tasks of the affiliates is maybe to find new affiliates and create more affiliates. So welcome. Okay, I don't see any urgent questions. So maybe from all what we heard, I mean, there can be a lot of discussions and bringing things forward. And I tried to put at least on the chat, on the answer list, a link to the Fire chat, where we have a topic on vaccination under Europe. And this is, of course, a very sustainable way of bringing our discussions here forward and continuing them. I hope it's usable and people can see it. All right. So now looking a little bit at the questions that I also put on the agenda. As we saw all those different approaches, what's the role of the affiliates in bringing that forward and bringing things? How can we act as affiliates in bringing also together those different solutions? Can we do something or not? I would start with Roland, because he already explained some export that his specifications are reused in another country. So maybe Roland, you have some ideas what the role of the affiliates is in that process.
I think yes, we should look more over the borders to look what the others has done. I've also pretty seen now how much is going on in different countries, and I think we are all doing in more or less the same direction, some implementation guides, some things, and perhaps it would be nice to have more such webinars to exchange this information, to have a platform to see what is going on in the countries. Because yes, we will travel again. We will have our electronic certificates with us, and yeah, the big questions were always in the question. Yeah, but how do we exchange between the countries? As I read the questions, it's more than once I saw it. Yes, in principle, different countries are making FHIR or they're making CDA. We make both now, and we make a mapping. But yeah, the problem is the vaccinations against diseases are the same, but the vaccines are not the same. The coding systems are not always the same, and therefore I think yeah, it would be nice to have more the exchange between each other. And for me, the question is somehow where can the World Health Organization help also to go in this direction?
Yeah, that's a valid question. Should it be European or should it be global? I thought that you would answer a little bit more with what you mentioned, that you also have private initiatives, because that was something in Switzerland that struck me, that you have a private-public partnership kind of that, as you explained. So just passing on this question, can the affiliates maybe connect or act as a bridge to bring private money also into the projects and connect it with government projects, with public health projects? I just pick Jose and Jens to answer.
Jose, you start.
Thank you. No, I don't have any strong feeling or any experience there. I think the governments are doing this. It's our role to tell the governments that if we do this alone, we will spend much more money. We will, and the companies as well. So we will spend much more money and much more time. And by the time that we do it, sadly, many more lives are going to be lost because we cannot have the solution in place yet, or we did not use the information to see what was happening globally. So that's the only contribution that I can do, is like as a forum, that what we do as affiliates and what we have in our participation with public or with private entities. That's what we can do, is to say there is a huge value in the community that we are discussing.
Okay, Jens, something to add?
Yeah, I fully agree, but I see it's so. In Denmark, standardization itself is a hard sell, whether or not you're public or private. But I do believe it's an absolute necessity if we need to have digitally verifiable passports, whether or not they contain COVID information or not. But that is an absolute must-have. And the question is how much we as affiliates can do when we do know there are initiatives in the EU Commission trying to establish a single standard, and as well as in the WHO. I can add as the last detail that I've worked a bit with the technical specs and tried myself to see how much, if you base this passport on QR codes, how much information you can actually put down into a QR code. And it is rough. So if you go to high resolution, you can go up to 3,000 bytes, which is not much, especially not for JSON encoded resources. So I actually believe if we are to encode information into QR codes, we'll probably end up using something like the semi-proprietary protobuf protocol, probably bounded to the FHIR model. That gives a compression rate of roughly 50%.
So that's the implementer's perspective. Well, just as some background, I mean, because Jose and Jens, you both are, as I understand, in an affiliate that is kind of part of an umbrella organization that is so it's not really a private initiative. It's more like a group of sponsors that together carry that affiliate.
Yeah.
So
we both have private actors and public actors. So we have the officials from healthcare authorities, and we do have other providers inside the affiliate.
Yeah. All right, so we're running a bit short of time, and I don't want to cut Catherine's closing remarks too short. So maybe I stop the Q&A here, and we can continue on the chat. And I pass the floor to Catherine for 5 minutes. Sorry, to have some closing remarks. Catherine.
Thank you very, very much, all of you, for this amazing webinar, web conference. it is so rewarding to see people from different environments coming together to discuss such a hot matter. And personally, I'm very grateful because I learned a lot. I'm also conscious that we still have 148 attendees. We reached 170 attendees in the beginning, and we have a lot of questions also in the Q&A box, and the people that wish to speak. We will not forget you. We have we will record all these questions and answer to each of you individually from the panelists. I would like to highlight that running this webinar, we also put a question on LinkedIn regarding the guidelines of the European Health Network on proof of vaccination for medical purposes. We had, as you may see, 20 responses. And out of these responses, there was, let me get the latest numbers. There were 25% that knew about them, 10% that knew but have not reviewed. But the most of the people, and this was from the attendees of this webinar, 65% did not know about these guidelines. I also note that from the people that spoke today among us, Ireland was very clear on the fact that they are implementing this guidance by the health network. Norway is aligned to that and is moving forward in that. That's what Lina said. Giorgio shared with us that they are working also to align with the work in the health network, but also with the work of WHO on vaccination certificates. And then there was a gray area when we heard from the other countries. I must also share with you that many years ago, working together, HL7 Europe and CEN/TC 251, we put together a roadmap for health standardization in the standards project. And listening to everyone on this webinar today, I realized that this is exactly what we are doing. We are closing the loop between policy making to actual technical specifications and the implementation thereof. So in that regard, I am extremely happy that we are actually moving to what Marcello Melgara might say, one of the veterans in this space, interoperability of minds. And for that, I really would like to thank you, each and every one of the speakers and of the attendees. We hope to work with you more in the national level, in the European level, and also internationally, because I must share as well that about half of the attendees are not from Europe, but around the world, from the US, from Australia, from Brazil, from all over. So thank you very much for being with us. This is a pandemic, and this is a digital transformation, and it takes a village, actually a global village, to reach the level of interoperability that is necessary to elicit the response that will solve the problem for now and forever. Thank you very much, everyone.
Thank you, Catherine. Well said. Thank you so much. That was very useful information, and as Catherine said, a well-attended webinar. Hopefully, we can continue this discussion at some of our future events. Till we meet again. Bye, everyone. Bye to all the panelists. Enjoyed working with you.
Bye.
Bye. Thank you.
Bye.
Bye.